Hello. Thank you for joining us for Gaining SFR Stakeholder Buy-in. Before we get started, I'd like to remind everyone of the requirements for receiving continuing education credits or a certificate of attendance. At the end of this session, I'll read off a 4-digit code which you will need to be recorded on the CE certificate for today's event. You'll find additional instructions on the front of the CE certificate available at the registration table. Each of you should have gotten one. If you did not pick up a copy when you checked in this morning, I have a few extras with me. Please be sure to complete the post-event survey before you leave today. The QR code for the survey is on the back of the CE certificate. You should have 2 copies of the certificate. Make sure you fill out both of those today and get both signed before you leave. Now we'll welcome Nicole Marks and Kalynn Sommers to begin their presentation. We'll let them introduce themselves and get started.
Okay, so I've never spoken to a group this big before, so I'm a little nervous, so just bear with me, all right? I have notes and everything, so we're gonna be fine. And I've never used a clicker before. Okay, so in Hancock County, we're very rural. It's located in Northwest Ohio, and we have a population of 55,000 or so. Sorry, I didn't want to be too close to it. The largest city in Hancock County is Findlay with a population of 40,000. It does come with challenges being rural because it's hard to it's just hard to get people to commit to it when the numbers are considered low, like compared to bigger cities. We have a combined overdose fatality review with the suicide fatality review. I don't know if it says it later or not, but we were doing overdose reviews in 2016 and then just recently added the suicides to it when we got a full-time physician to do the reviewing. It does say it right there. I'm not even looking at it. So the position is funded through the state opioid and stimulant response grant, and then our local admin board also helps fund that position. So the admin board is present almost at all of them. We send out like a cheat sheet beforehand to people who are in the group but don't always participate. So if they have any information on the decedent, they can send that back to us, and then we can relay the information to the committee. So if any of these people are not present, we still get their information because not everybody can attend every meeting. And then like the local school district will still come if it's a person that's graduated recently, even though if they're over 18. So I think typically they do it if they're under 20, they'll come in and talk about their school and their academics and stuff. And then Veteran Affairs comes every time, even if they don't have, they're very active in our committee. They come even if the decedent's not necessarily a part of the Veterans Affairs. And then we have several local behavioral health facilities. And typically what we've noticed, a common thing is that each facility will have something on a person. Like a common thing is that when decedents will go to multiple facilities in their lifetime, so almost always they have stuff on the person that we're reviewing. Our coroner is invited. He doesn't come very often, but he does allow us to look at records. In 2021, 20 decedents were 20 deaths by suicide were reviewed and 20 overdose deaths were reviewed. In 2022, we had 28 deaths by suicide and 20 overdoses that were reviewed. We're still waiting on final death certificates for 2023 to finish that up, but we're looking to finish that up at this next quarterly meeting in November. But real quick before we move on, I just wanted to say that for 2024, so far the numbers in Hancock County are for both overdoses and suicides are much lower than they have been previously. So I'm not saying that we're doing all the work, but like as a community, we're definitely getting somewhere with the recommendations and everybody putting in their part. The overdoses are significantly lower. We're down, we only have 1 confirmed overdose this year. And then suicides are also lower, but we don't have any confirmed death certificates on those yet for final numbers.
All right, and in Huron County, we're pretty similar to Hancock County. So we're a rural community that's located in north central Ohio. We have a population of about 58,000 residents, with our largest city being the city of Norwalk with 17,000 residents. And we have major industries of agriculture and manufacturing, which you'll see can possibly tie into your fatality review depending on what the industries in your community look like. So our drug overdose and suicide fatality review committee is, again, like Hancock County, a combined SFR OFR committee, and we facilitate it at the health department. We've been meeting a little over 2 years, with our first meeting being held in July of 2022. And until now, we've been unfunded, but this year we will receive $10,000 in funding from the Suicide Fatality Youth Suicide Prevention Grant from the Ohio Department of Health. So this is our SOFR committee makeup. I won't go into all of them now because that's what my section of the presentation will be. But I do want to give you a little bit more of a background of our committee. So our committee meets quarterly, and we are 2 quarters behind. So we give a little bit of a built-in delay to allow our members time to gather case information, investigate deaths, and put everything together before the meeting. And we are small. Again, like Kalynn said, our numbers are very small in Huron County, and so we make an effort to review every death in our county. So you can see here in 2022, we reviewed 9 cases. In 2023, 23 cases. In 2024, 15 cases were reviewed up through July. So looking at SFR membership, this first section will kind of talk to some of the partners that Kalynn and I have at our tables, and then Kalynn's going to go through some of the successes and challenges that we've had getting those people to the table. So starting off with the required SFR members, the Ohio Revised Code does outline basically how these committees have to be set up, right? So you can do a single county SFR, you can do a regional SFR, but both of our counties have established hybrid drug overdose and suicide fatality review committees, and both of ours are single counties. So just keep that in mind, that if you're looking at doing a regional committee or just a standalone, that it might look a little bit different in your community. So the required SFR members, starting off with the health commissioner. The health commissioner is appointed by the county commissioners to establish that committee. So that's kind of the first person that you want to get to the table. And then there's 4 additionally required members. So first, the chief of police of the police department in the county or region, or the county sheriff designee, or the chief of the sheriff. You also want to have a public health official or the health official's designee, the executive director of your MHOS board or their designee, and then a physician authorized in the state of Ohio to practice medicine and surgery. The county coroner should also be invited, but they're not required to accept the invitation. And one thing we wanted to make sure was clear throughout this presentation was, if you don't have some of these partners at the table, all of these partners at the table, don't let that stop you from getting into this important work. As you'll see, even just between our 2 counties, there's some people that are at the table in Huron County and not at Hancock County, and vice versa. So again, we kind of want to talk about extending beyond what is required. So the Ohio Revised Code does allow additional members to be invited to serve on the committee. Committees are typically comprised of 15 to 30 members, and you want to think about making them be multidisciplinary in order to identify as many contributing factors as you can. So think about things like professional experience, lived experience, diversity of the actual committee members, those types of things. And really think about it in your specific community's context. Again, Hancock County and Huron County might look different than your community, and that's okay. Some things that work for us might not work for you, and you guys might have great partners at your table that won't work for us. And again, they might be stronger or more involved in some counties versus others. And we do want to hear from you at the end of the presentation, just ideas that you have of people that you've brought to the table that maybe we didn't address today. But these are going to give you some examples of ideas of sectors that have been beneficial to our counties. So starting off, obviously the coroner is someone that you're going to want to think about having at the table. A coroner can provide information specific to the death scene, specific to the autopsy. They might have additional information from family members or others at the scene, like neighbors. They can also report on a decedent's ORS report, so talking about their history of prescription, whether they were doctor shopping, that kind of thing. As Kalynn mentioned, in Hancock County, the coroner is invited but isn't often able to attend. However, they do allow them access to their records, and so they're still getting that vital piece of information for their review. In Huron County, our coroner is actively involved, and he typically attends all of our meetings. Healthcare is probably another pretty obvious sector that you want to talk about inviting to the table. Healthcare providers can provide insight about the decedent's health history and interactions with the healthcare system, both at the time of death and prior to the death. And again, both of us have these healthcare partners at the table. Substance use and mental health treatment providers, again, probably a pretty obvious one, but they can add additional important information about the decedent's history of drug use, mental health concerns, co-occurring disorders, and interactions with substance use and mental health treatment. Again, both of our counties have these types of players at the table. Veteran serving organizations. Again, this is something that was mentioned during the opening this morning. Veteran serving organizations can provide some context as to how veteran healthcare in the VA system works, which has been a learning curve for me and I'm sure for a lot of you out there as well. They can provide insight into the processes and procedures that veterans may encounter in getting healthcare and maybe some of the roadblocks that they encounter too. We've had some cases where it plays a role that they've gotten some sort of a denial from the VA, and that was a significant part of their background or history. So it's important to have those people at the table that can explain why this is happening and how we can help people in the future avoid these types of delays or issues. One of the potential barriers that I did want to note with this partner is just that we have ran into some issues with the fact that basically the VA can't share a lot of the records. Now, this morning she mentioned there might be a potential way around that if the family is willing to share records. So definitely something that we want to look into in the future. As was mentioned earlier, Hancock County and Huron County, we both have our Veteran Service Office at the table. And then for Huron County, we also have our VA Northeast Ohio Healthcare System Suicide Prevention Community Engagement and Partnership coordinator at the table, and she is very helpful again to kind of just provide some of that context of how the VA system works, but also she's been able to provide us a lot of different resources on free trainings that people can attend, a lot of them being virtual. She's also given us resources for things like gun locks and those types of things. So if you're not sure who your coordinator is in your region, I would definitely recommend reaching out to them and getting them involved in the committee. Another sector of partners that we wanted to talk about was county, city, village representatives, including first responders. So again, like the coroner, they can oftentimes a lot of times provide information about the scene on the day of the death, and that can provide insight into the situation. But they can also provide information on whether they've been to this house a lot of times or they've had frequent interactions with the decedent. So you'll see we've got police departments, sheriff departments, fire, EMS involved, all good partners to have at the table depending on how your county is made up. The court system is another partner to consider. This looks a little bit different for Huron County versus Hancock County. So in Hancock County, they have probation and youth probation both at the table. They're able to provide kind of some of that history both on the decedent and the family history of the court system and their compliance with probation. In Huron County, we haven't had them at the table, but when we started working with Hancock County, that was one of the people that we thought, wow, we should really try and get them on board. So that's something that we're currently working on. And then in Huron County, we have our prosecutor's office at the table. That was someone that we found was important to involve in the beginning, and how we kind of utilize them is not only do they sit in on our meetings, but beforehand we send them a list of all of the cases that we're wanting to review for that quarter, and they give us the thumbs up or thumbs down. If there's an open investigation or some reason that we shouldn't be reviewing a case, they'll tell us to hold off and we'll wait until it's appropriate to review that case. And then, as I'll get into next, the social services with Job and Family Services and other county agencies coming to the table, that prosecutor's office being at the table also helps, because sometimes we'll see them kind of look across the room at each other and he'll kind of give them the okay, like, yes, it's okay to share this, or no, it's not okay to share this information. So when we have Job and Family Services at the table, it's also helpful to have the prosecutor there to kind of give them that comfort level of being able to share. Job and Family Services may be able to speak to things like whether ACEs have impacted the decedent, whether they've known them since a child growing up through the system. They can also speak to if there's a suicide or overdose death, whether there are children that are directly involved in that situation that are going to need follow-up care down the line. Schools is another one that Kalynn already mentioned, but like she said, they can provide additional information about kind of family concerns, behavioral educational concerns during a time at school, and you can potentially be selective here. So thinking about coaches, counselors, principals, superintendents, really thinking about who might be the most relevant participant based on the scenario. In Hancock County, again, they're invited, but until a death happens, they're not really actively involved. Similarly, in Huron County, we only invite the schools if a decedent is under the age of 25, because our schools have indicated that they typically keep records for around 7 years. So if they're under 25, we're reaching out to the school to see if there's any information they can share. I did want to note here with those younger cases, if we do have a case that's under the age of 18 where there's a child fatality review that needs to happen, we're coordinating with our child fatality review coordinator so that we're reviewing the case one time, but everybody that needs to be at the table is at the table, and we're only making everyone sit through the review one time. So just something to keep in mind. And then funeral homes. This is one that you might not think about, but for us in a small rural county, we do have one of our funeral homes at the table, and they can often provide anecdotal information from family interactions that aren't really recorded in a formal behavioral health record or healthcare record. And our funeral home is very involved in the community just in general, so they might just have some other important information to give context to the situation. And then colleges and universities. This is something that we don't have in Huron County, but in Hancock County, they invite a pharmacy professor from the University of Findlay, and they help them kind of understand drugs that might be in play in a situation or drug interactions that are involved in cases. Again, not something that we have, but if you do have a college or university in your community, another important sector to try and reach out to. So we'll hold this to the end, but we want to get you guys thinking about what sectors we didn't include that we're missing, and what ways we should be utilizing our partners that we didn't talk about. And in your fatality review manual that you were provided this morning from pages 11 to 13, there's going to be some additional examples of professionals that may be invited and some practical guidance for recruiting additional members. And with that, I will hand it over to Kalynn. She's going to talk about some of our successes and challenges with our membership.
A lot of our partners have concerns surrounding confidentiality and their ability to share information because they're used to not being able to do that. Share ORC sections on immunity and confidentiality. An individual or public or private entity providing information, documents, or reports to a suicide fatality review committee is immune from any civil liability for injury, death, or loss to a person or property that otherwise might be incurred or imposed as a result of providing the information, documents, or reports to the review committee. Each member of the review committee is immune to any civil liability or injury, death, or loss to a person or property that might otherwise be incurred or imposed as a result of the member's participation on the review committee. We also have a non-disclosure agreement that we send out to everybody. And we used one from an example from the overdose fatality review manual because we didn't have the suicide one yet, but it's very similar to the one in the overdose manual. I have some notes here. Hancock County also has access to our local health system records. They give us access to it, and we have data sharing with them, so we can look at their medical records. There's not always information in there, but sometimes there is. How do we successfully make improvements after identifying gaps without pointing fingers, blaming, etc.? Partners might get defensive about discussions rather than try to correct the issue, which could impact participation. Set ground rules from the beginning that your meetings are at no-fault learning environment designed to improve community process and save lives. Have conversations one-on-one with partners if necessary. So a lot of our partners in Hancock County have been really fabulous about filling the gaps. Nobody really takes it personally, which is awesome. For an example, we have where we noticed that pain management was a common denominator in a lot of our decedents, and they were very open to doing extra assessing of their patients, and it has seemed to help. So how do we successfully make improvements after identifying gaps without pointing finger? Well, I already read this. Sorry. I thought I hit the button. Competing schedules, staffing shortages, turnover, meeting schedule barriers. We no longer provide food at ours. we had somebody that was donating it and they stopped doing that. And after that, we seemed to notice that people showed up less. Like, I hate to say that food brings people in, but it does. Another thing that we also noticed is that sometimes the wrong person from an agency may be there. So for a while from the local hospital system, we had someone from the emergency department there when really we should have had somebody from like the psychiatric unit there. So not that it wasn't the right place, it just wasn't the right person within the system to help us with our needs. And then we often need re-education for our participants because there's a lot of staff turnover rate. But our mental health board is really good about sending out continued education to a lot of the people in our committees. So they're very well versed in the proper language and the correct things to say. So it's helped a lot. Sending out the quarterly meetings in advance, they were doing it a year in advance, and that made it so more people could come. Recently, we haven't been as good about it, but it was because we were short-staffed. But now I hope that it'll get back to sending them out a year in advance. Some challenges that we have: how do you show partners that the process is working? It's hard to show improvements with something that's only been occurring for a couple of years. But I will say that with the overdoses, which we were reviewing long before the suicides, we have seen the decrease, as I recently stated. So like I said, something that we're doing is working. And for 2024, the suicide rates are down as well. So we're hoping that we'll continue to see that in the upcoming years. Good working relationships tend to increase trust and sharing, which helps decrease workload for partners. The coroner may not attend our meeting, but Hancock Public Health is allowed to look at records. We said that already too. I already said that too. Sorry, I get ahead of myself. Partners learn differences about programs and services offered or available in the community. This helps all agencies involve better navigation of the system and better assist clients. This gives partners a better understanding of how different agencies work, as well as the limitations where others can help fill gaps. Further distribution/reach is crisis cards and education information. So the crisis cards, I just want to touch a point on this. We created, in the committee, it was recommended that we create something that we can give out to people in any crisis, right? That our first responders could give them with like 988 information. There was another hotline number on there. And while creating the cards went very well, the utilization hasn't been great from our law enforcement. Nothing on them. They have a lot going on. I understand why it is a challenge. And they want to help, but they've got a lot going on. So if they had a card for every incident, you know what I mean? So we're working on that one. Not only do partners learn about available services and trends, every meeting is a learning opportunity. Setting the expectation that there are no dumb questions can sometimes lead to simple solutions that others may not have thought of. Encouraging different perspectives can lead to positive changes.
So if you guys have any questions, or if you want to share some of the sectors maybe that you've had at the table that we didn't mention, or other ideas that you kind of want to bring up for the group, we'll hear those now.
The only partner that we have at the table that you didn't mention, and it's probably included in some of the groups that you have, is victim assistance. They meet with a lot of people after suicides. I'm in Summers County, and our OFR SFR combined as well. So they're able to give us that context of the need that someone may not be comfortable giving to a first responder or a member of a person who has like that authority. They might feel a little bit more comfortable speaking with victim assistance. Victim assistance often follows with the family for a little while, so they get a little bit more of like the family perspective on that person. So we haven't had a whole lot of success with next in interviews. That's the closest that we have, and it's been really helpful.
So victims assistance, for those of you that couldn't hear. As far as next of kin interviews, do you guys do the psychological autopsies, or is it a time issue for you guys as well?
Mostly a time issue. I'm actually like partially way through the process of getting the psychological autopsy training and certification. So we follow the national OFR guide for next of kin interviews.
I think that's a very important partner to have at the table. I don't know if you guys.
Yeah, I do on this one. So we're working on a grant right now we're calling it Suicide Overdose Survivor Support, and it's a lot modeled like a loss team that will run through the health department. We'll have volunteers that will follow up for people who survive and also don't survive suicide attempts and overdose deaths. So we're hoping to walk with them in that same aspect. Instead of having like an outside agency do it. So like right now I do follow-ups with overdoses, but not suicides. So because again, we just recently adding that, we're trying to incorporate it a little bit more, and then hopefully we'll be able to get volunteers in on it, and it'll expand a little bit more. But I definitely think that's a vital part of it, having somebody walk through it with them in the beginning months, especially.
So for our county, and the question was, what do you do to increase buy-in for those people that should be at the table but maybe just aren't at the table? One of the things that's worked for our county, so when we initially started up, we sent out kind of these formal invitation letters, and there's an example of that in your manual of kind of what that looks like. But we sent out all of these invitation letters. Some people organically came to the table knowing that this is important, this is something that we've been working on, but for others, they didn't show up that first meeting. And so honestly, I don't know what county you said you're from. But go ahead. Okay, so small rural county, right? So for us, kind of what worked being a small rural county was our health commissioner just reached out to people one-on-one. And that is something that kind of holds a lot of weight with our partners, is just that reaching out to them personally by phone and explaining to them why it's important, what we're doing, especially the confidentiality piece, having that explained, I think, was a big gap for a lot of our partners, because like we talked about, they were scared to share. And they didn't know what they were legally allowed to share. So having the prosecutor at that meeting, so when they came to the first meeting, he was able to sit there and say, this is okay, this is the ORC that tells us that this is okay, you're allowed to share, this meeting's confidential. That was a huge barrier for us at first, but once people started coming and understanding that this meeting is truly kept confidential, and then we take the recommendations outside of the meeting, I think that really helped with their comfort level. And then once we started taking those recommendations outside of the meeting and they saw things actually changing in the community, or we're doing this education outreach or whatever we might be doing, I think that also helped, is showing like we're not just meeting to meet and review these cases, we're making hard recommendations and then taking them outside and actually doing the work. Does that answer your question?
Yeah, I said, the prosecutor is very helpful. Thank you.
Okay. Good job.
One of the partners that we have at our review is the Ohio Board of Pharmacy, which has been extremely helpful for the overdose cases. They're the ones, I know you mentioned the community pharmacy school, but they're the ones that do and pull our ORS reports and gives us any checks for red flags, as well as we can ask them to open investigations if we have concerns for things that don't look right.
So on our county, we have a sponsorship for ORS. So my SOFR coordinator can look at their ORS reports on their own, because we have our medical director sponsor her to do so. So we get to look at ORS, which I've heard from other people can be tricky. We haven't had any challenges with it personally, but other counties, when preparing for this, said that there was some miscommunication and it was just a little difficult to like the legality of it. But I'm sure I don't know. You know, we look at our own. So, but that's awesome that you have somebody to do that for you. Yes.
So the psychological autopsies was brought up next to kid interview. So that's a valuable, our group, we've met a couple times now. I think that's a valuable bit of information that if we're really going to make some strides, I think we need to find a way to get that information in addition to the other folks you have up there, which is wonderful. Our challenge is trying to find a kind of a home for who does that and under what authority that the psychological autopsy takes place. And again, whether you have ideas or anybody in the room, that's one of the things our group is struggling with. We want those to happen. We see the value of it. We have some folks even trained, but under what authority are they doing those? And that's where we've been struggling to figure out whose employee, if you will, should they be. So whether you have any thoughts on that or anybody in the room, that'd be helpful.
I'll just add our perspective while the mic is moving. For our county, our mental health board director is the one that is trained to do that. However, I will say they're a mighty team of 3. And so when we're asking them to do these psychological autopsies that take a lot of hours to get them done, that's been a challenge for them. So one thing that we've talked about, and I think you guys have a full-time position. We don't. So that's a great thing to be able to have if you can find funding to find someone a home and funding to just focus on that. That's one thing that we don't have that I wish that we did have, because that time is a barrier for us. But for us, it lives at the mental health board.
I don't really have a response to that. I have a different question, so I don't know if someone else. But have you ever explored the idea of inviting an individual's payer to the table, particularly if they have a Medicaid plan? And if you have, what barriers, like if that was not an option, what barriers have you encountered?
Can you repeat the question, hon?
If you've invited the payer, so if they have a Medicaid plan or whoever their insurance is, have you?
No, I don't think we've ever thought of doing that, no.
Okay.
Because we have access to their medical records. In our county, the hospital system that we have is literally like does all of it, right? So if somebody's active in the medical system, we can see if they went to primary care, the emergency department, the psych, like we can see all of that by having access to their records. And I don't know that we've encountered a person yet that hasn't been in that system if they lived in Hancock County. There are the occasional ones where the decedent dies in Hancock County but isn't a resident. So like when those situations, we don't have a lot of information on them. But if they live in Hancock County, they've almost always been a part of this system. So it's a little different for us. I'm not sure how your specific county works, but we've never thought of inviting their insurance, no. I'm just gonna stand over here instead of standing up.
All questions have to be in the same spot. That's fine.
Hi, I'm April, and I'm from Harrison County, so with the coroner's office. And so after looking into this and being set up to come here, because I was not familiar with this process, I am a part of the Child Fatality Board as well as the Drug and Alcohol Coalition of our county. But I've never heard of anything being presented in our county for suicide prevention program. So as looking at the regional map, I noticed that our county is not listed anywhere. So is there a county, like how do we know what county we are to report to if we don't have a base in our county? Is that something that we just reach out to other counties closest to us, or is that based on what is assigned to us for our county? Like who do I go to get this implemented?
I would probably recommend, do you report to multiple counties? Is that what you're saying?
I don't even know. I've never reported to anybody, honestly.
You have a local health department?
Yes, and that's where I do my child fatality board through.
Okay, so whoever leads the child fatality review, I would start with them and then tell them that you're interested in this topic and see what possible outcomes could like what your options are as starting something similar to this. And then go from there. That's what I would recommend. If you're reporting to multiple counties, maybe talk to each health commissioner individually and then see if it's like regional. You can also do that under the code.
And we would find out if we're already involved in this with the health commissioner?
Yes.
Okay.
If you're already involved in it as a coroner, you should know because they have to invite you as a coroner to it. So it's probably not happening if you don't know about it.
Yeah, we don't know about it.
Then it's
Yeah.
probably not happening.
Okay. All right, thank you.
Yeah.
Hi, I just wanted to speak to Stark County, how it works here. You were asking about where the position is housed. So we had a psychological autopsy investigator. We initially started at our local mental health provider who was handling all of our crisis work, and we had so many challenges related to data sharing, so that didn't work. We then explored would it work better at our local health department. That didn't work either, just for various reasons. And then ultimately we landed at our coroner's office. So our mental health board funds a position to be housed at the coroner's office, and it just works so far. Susan is here, brand new, but it's working beautifully so far. It just alleviates so many barriers.